Suppose someone asked you right now, not your doctor, not a pharmacist, just someone sitting across from you at a kitchen table, what exactly is that pill you're swallowing every morning actually doing inside your body? Not the name on the bottle, not the one-line description on the pharmacy receipt. The real answer, the mechanism, the way it quietly interacts with your heart, your blood vessels, your kidneys, every single day. The warning signs that separate something manageable from something that needs urgent attention tonight. If you pause before answering, even for just a second, that pause is important. Because that pause is where real harm quietly lives. These are not mild medications. They are not the kind of thing you take the way you take a multivitamin and move on with your morning. Amlodipine, Losartan, and Lisinopril are powerful cardiovascular drugs. They change the way your heart pumps, the way your arteries respond to pressure, the way your kidneys filter your blood. They do this every single day, around the clock, whether you're thinking about them or not. And yet, the number of people who take these medications for years without ever truly understanding them is staggering. Not because those people are careless, but because nobody ever sat down and explained it in plain language. That changes today. My name is Dr. Raymond Caldwell, and the entire reason this channel exists is to give you the kind of honest, practical medical clarity that tends to get squeezed out of rushed appointments and vague pamphlets. By the time we finish this conversation, you're going to understand these 3 medications in a way that makes you more aware, more protected, and far less likely to be blindsided by something that was entirely predictable. I want to start with a man named Gerald. Gerald was 76 years old, a retired civil engineer who had spent decades managing large infrastructure projects with the kind of methodical precision that most people can only admire. He took his medications exactly as prescribed, at the same time every morning with a full glass of water, logged in a small notebook he kept in his kitchen drawer. When his physician added amlodipine to his existing regimen, Gerald treated it the way he treated every change in any system he managed. He noted it, adapted, and assumed everything would proceed normally. What Gerald did not expect was what happened to his legs over the following 3 months. By mid-afternoon, both ankles had begun to swell noticeably. His shoes, ones he had worn comfortably for years, began to feel tight by early evening. His legs felt dense and heavy in a way that made him reluctant to take his evening walks. He started researching his symptoms at night, and what he found terrified him. He became convinced his heart was beginning to fail. He started rationing his activities. He told his wife he thought something serious was progressing. The anxiety compounded daily. The truth was far simpler and far more correctable. Gerald did not understand that amlodipine, Losartan, and Lisinopril are not 3 versions of the same drug. They lower blood pressure, yes, but through completely different mechanisms, and those mechanisms produce completely different patterns of side effects. Understanding that difference is not a technical detail for medical students. It is practical, protective knowledge that belongs in the hands of every person who takes these medications. Amlodipine is what pharmacologists call a calcium channel blocker. Inside the walls of your arteries, there are smooth muscle cells that contract and relax to regulate blood flow. Calcium plays a key role in triggering that contraction. Amlodipine blocks those calcium channels, so the smooth muscle relaxes, the artery walls widen, and blood moves through with less resistance and therefore less pressure. It is an elegant mechanism, and it is effective, but affects arteries far more powerfully than it affects veins. Arteries carry blood toward the tissues. Veins carry it back. When the inflow pathway is relaxed but the return pathway remains relatively unchanged, fluid accumulates. It pools in the lowest points of the body, the ankles, the feet, the lower legs. That is what was happening to Gerald. Not heart failure, not kidney failure. Amlodipine doing exactly what amlodipine does in a meaningful percentage of people who take it. Once that was identified, and once Gerald's care team explored the right adjustments, he was back in his walking shoes within a matter of weeks. The critical lesson is not that amlodipine is dangerous. It is that misinterpreting a known and manageable side effect in silence can rob people of months of quality life and fill that time with unnecessary fear. Leg swelling on amlodipine is not something to endure quietly. It is something to report, discuss, and address. There are strategies. There are alternatives. But they only become available once the conversation happens. Now let's talk about lisinopril and the side effect that has probably disrupted more sleep for more people than almost any other medication-related symptom in this category. The cough. Not a productive cough that brings something up. Not a cough that gets better with tea or throat lozenges. A dry, persistent, maddening tickle that camps itself in the back of your throat and refuses to leave, typically worsening at night, completely unresponsive to anything in the average medicine cabinet. What makes this side effect particularly treacherous in terms of being identified is the timing. It does not always arrive in the first week. Some people develop it within days of starting the medication. Others don't notice it until 3, 4, or even 5 months in. By that point, the connection to lisinopril is almost never the first thing anyone thinks of. The drug has become invisible part of the routine. And so people blame seasonal allergies. They blame air quality. They blame reflux. They buy air purifiers and try antihistamines and schedule visits to the allergist, and the actual source stays hidden in plain sight. Consider a woman named Patricia, 73 years old, a lifelong amateur botanist who spent her spring and summer mornings tending to the garden she'd been cultivating for 30 years. When a dry, nagging cough appeared one April, she had no reason to question the timing. Pollen was everywhere. The season had started early. She treated it as an allergic response, made adjustments to her outdoor routine, and waited for it to pass. It didn't pass. By autumn, it was still there. By the following winter, it was interrupting her sleep several nights a week. She was exhausted, increasingly frustrated, and starting to worry that something was being overlooked in her care. When a thorough review of her full medication history was finally completed, the sequence became visible. Patricia had started lisinopril approximately 4 months before the cough appeared. She had never once considered a connection between the two. When her physician confirmed the likely cause and coordinated a transition to Losartan, a medication that works at a similar point in the blood pressure pathway, but through a different receptor and without the cough side effect, Patricia's throat cleared within 2 weeks. Almost a year of disrupted sleep, 2 weeks to resolve it, once someone finally asked the right question. That said, and this must be stated with absolute clarity, there's a symptom in the lisinopril family that is not a manageable nuisance. It is a medical emergency. If you're taking lisinopril and you notice swelling developing in your lips, your tongue, your face, or your throat, especially if you feel any tightening, difficulty swallowing, or trouble breathing, you do not wait for the morning. You do not take an antihistamine and monitor the situation. You contact emergency services immediately. This reaction is called angioedema, and while it is not common, it is unpredictable. It can escalate rapidly, and it can close an airway faster than most people expect. A persistent dry cough is frustrating. Throat swelling is a crisis. Those two things must never be confused, and that distinction should stay with you permanently. Losartan operates on a similar part of the body's blood pressure regulation system as lisinopril, targeting the renin-angiotensin pathway, but it does so through a different receptor and without triggering the cough response. For many patients who cannot tolerate lisinopril, Losartan becomes the natural alternative, but it carries its own distinct profile of concerns. And one of the most significant is something that catches people completely off guard precisely because it emerges from behavior they believe is healthy. Losartan, like lisinopril, has a tendency to raise potassium levels in the blood. For most people, when the medication is properly monitored and diet is relatively typical, this elevation remains within a safe range. The problem arises when additional potassium sources enter the picture without anyone realizing how much they're adding. And here's where the counterintuitive part arrives. Potassium doesn't only come from bananas or supplements that someone deliberately chooses. It hides in enormous quantities in products that are actively marketed as the responsible, heart-conscious choice. Salt substitutes. The one sitting on grocery store shelves right next to regular table salt, often labeled as low sodium or cardiovascular friendly, frequently replace sodium chloride with potassium chloride. A person who has been advised by their doctor to reduce sodium intake dutifully purchases one of these products and begins using it generously, doing exactly what they were told to do, while simultaneously loading their system with potassium on top of a medication already pushing potassium levels upward. Elevated potassium does not always announce itself dramatically. That's what makes it genuinely dangerous. It can surface as unusual muscle weakness, a fatigue that feels different from ordinary tiredness, cramping in the legs, a tingling sensation in the fingers or hands, or a fluttering irregularity in the heartbeat. Sometimes, in the early stages, it barely announces itself at all, and by the time symptoms become undeniable, the elevation has been building quietly for some time. Electrolyte powders, certain meal replacement products, and some over-the-counter sports recovery beverages also carry significant potassium loads that most people never think to mention to their physician because those products don't feel like medicine. If you or someone close to you has made the switch to a salt substitute in the last year or two, and that person is also taking Losartan or Lisinopril, that conversation needs to happen with a healthcare provider. Not as a cause for alarm, but as a matter of informed awareness and appropriate monitoring. There is another dimension to these medications that deserves far more attention than it typically receives, particularly for older adults. What happens to these drugs when the body's internal environment changes? Not from a new prescription, not from a major illness requiring hospitalization, but from something as ordinary as a stomach virus, a stretch of poor appetite, a hot week in summer, or a few days of not drinking enough fluids. These medications were calibrated for a body that is adequately hydrated and functioning within a normal physiological range. When dehydration shifts that range, even modestly, the same dose that was perfectly appropriate on a normal day can produce dramatically different effects. Blood pressure can fall too low. The kidneys, already working harder to compensate for reduced fluid volume, become significantly more vulnerable to stress. Dizziness, weakness, near fainting, and in more serious cases, acute kidney strain can develop far more quickly than most people anticipate. This is not a remote possibility. It is one of the most common and most preventable scenarios that arises with these medications. And the way to protect against it is straightforward. Before you ever need it, ask your prescribing physician for a clear sick day plan. Ask specifically what you should do with your blood pressure medication if you develop a stomach illness, cannot keep fluids down, or are losing significant fluid through sweating. Should you hold a dose? At what point do symptoms warrant a call? What signs should prompt you to go in? Write the answers down. Keep them accessible, because in the moment when you're nauseous, lightheaded, and trying to decide whether to take your morning pill, you do not want to be guessing. One more scenario that deserves its own moment of attention: arthritis pain, back stiffness, joint discomfort. These are not rare experiences for older adults, and a natural reach for ibuprofen, naproxen, or similar over-the-counter anti-inflammatory medications is completely understandable. They're accessible, familiar, and effective for musculoskeletal pain. But when used regularly alongside any of these 3 blood pressure medications, particularly in combination with a diuretic, they can meaningfully reduce blood flow to the kidneys. In the context of even mild dehydration, the risk of kidney injury rises in a way that nobody intended, and that could have been avoided. If you rely on anti-inflammatory pain relievers regularly for joint or back pain, please discuss that with your prescriber. There are often safer alternatives, from acetaminophen to topical agents to other approaches, that carry far less risk for your kidneys. You should not have to choose between managing your pain and protecting your kidney function, but finding the right path requires an open conversation. The final thing worth carrying out of this discussion is something that seems simple but requires a genuine shift in perspective. When your body produces a symptom while you're taking one of these medications, that symptom is not just an inconvenience to push through. It is information. It is the only language your body has available to communicate that something in the current equation may need adjustment. Swelling that makes you stop walking is information. A cough that steals your sleep for months is information. Dizziness every morning when you stand up is information. These signals are not a character flaw. They're not you being overly sensitive. They are data points that belong in a medical conversation, not endured alone in silence. The most effective medication is not necessarily the one that produces the best number on chart. It is the one that works within the actual reality of your life, your body, your other medications, and your daily habits. If a medication is producing side effects that make you dread taking it, the natural endpoint of that trajectory is the day you quietly stop taking it without telling anyone. Blood pressure climbs back up. Nobody connects the dots until something serious happens. That outcome is not inevitable. It is preventable. But prevention requires speaking up. Your observations about how you feel are not a distraction from your treatment. They are part of it. Watch for ankle and leg swelling if you take amlodipine and report it rather than adapt around it. Watch for a persistent dry cough if you take lisinopril, and recognize that lip, tongue, or throat swelling on that medication is an emergency requiring immediate care. Watch for muscle weakness or irregular heartbeat if you take Losartan, and take a careful look at what's in your salt substitute. Rise slowly from sitting or lying positions. Build consistency in how you monitor your blood pressure at home. Same arm, same time, after resting quietly. Never casually combine these medications with over-the-counter anti-inflammatories without guidance. And never stop any of them abruptly without speaking to your doctor first. You took the time to engage with all of this. That matters. Knowledge like this doesn't just ease anxiety, it prevents real harm in the lives of real people quietly and consistently, one informed conversation at a time.